Have you ever found yourself gazing at those mysterious squiggly lines on an electrocardiogram or ECG and felt like you were looking at a secret code?
hmm
Perhaps an ancient language only decipherable by a select few. It looks like hieroglyphics, doesn't it?
It really does, yeah.
But what if I told you that those lines are actually the heart speaking directly to us, sharing its deepest secrets about its health, its rhythm, and, how it's truly doing on the inside?
And what's truly fascinating here is that the ECG is far more than just a printout from a machine. It's an immediate, profound window into the dynamic electrical activity that underpins every single vital heartbeat.
Right.
When we understand its language, we can hear the heart's true symphony, appreciate its complex rhythm and harmony, or critically discern when it's playing a little out of tune, signaling that something might be amiss.
Exactly. Today, we're embarking on a deep dive into the captivating world of electrocardiography. We're going to walk through everything an elite professional would know, drawing directly from the foundational insights of what you might find in, say, a comprehensive medical text, Chapter 240.
That's the goal.
Our mission for you, our curious listener, is to equip you with the knowledge to truly understand the language of the heart. From the absolute basics of its electrical activity to the subtle cues that signal critical conditions, we want you to feel like you're gaining mastery over this vital diagnostic tool.
And this isn't about rote memorization of patterns.
No.
It's about grasping the fundamental electrophysiologic principles that make the ECG such an immediately available, non-invasive, and incredibly powerful test.
Yeah.
It's inexpensive, widely accessible, and remarkably versatile. It allows us to detect everything from common arrhythmias and acute myocardial ischemia to potentially life-threatening metabolic disturbances, or even the hidden risks of sudden cardiac arrest.
Wow.
It's undeniably an indispensable tool in modern medicine, and by the end of our conversation, you'll understand why.
Okay, so before we even get to the squiggly lines themselves, we need to understand the very origin of the heart's power. How does the heart actually generate the electricity that an ECG detects?
hmm
What's truly happening at the cellular level that sparks these impulses?
That's the perfect place to begin, because the ECG is simply reflecting these fundamental microscopic processes. Every single cardiac contraction is initiated by an electrical event called depolarization.
Depolarization.
Think of depolarization as the cell's electrical firing or activation.
Right.
Immediately following this, the cell undergoes repolarization. That's its electrical recovery or resetting phase.
Okay, resetting.
And it's crucial to understand that the ECG from the surface of the body records only the electrical potentials generated by the working muscle cells of the atria and ventricles, the actual myocardium.
So not the pacemaker cells directly.
Exactly. It doesn't directly pick up the activity from the tiny specialized pacemaker cells or the rapid conduction tissues themselves, though their activity initiates everything we see.
Ugh. So it's like we're listening to the collective sound of a grand orchestra playing a piece, not directly hearing each individual musician or even the conductor's every nuanced gesture. It's the grand output.
Precisely. That's a great analogy. And this incredible electrical symphony is orchestrated by three key components working in perfect harmony.
Okay.
First, you have the cardiac pacemaker cells. These are truly remarkable. They possess the unique ability to spontaneously generate their own electrical impulses, setting the underlying rhythm of the heart.
Automatic.
Yes, automaticity. Second, there's the specialized conduction tissue. This is the heart's internal wiring system, a superhighway designed to rapidly and efficiently transmit that electrical impulse throughout the heart's chambers.
The wiring.
And third, you have the heart muscle itself, the myocardium, which is the workhorse. It contracts powerfully in direct response to these precisely timed electrical signals.
So it's a beautifully coordinated electrical journey. Where does this electrical journey begin, and how does it spread throughout the heart to create a heartbeat?
The journey begins at the heart's natural pacemaker, a small cluster of specialized cells known as the sinoatrial node, or SA node.
SA node.
Right. This node is nestled in the upper part of the right atrium, and it's unique because of its inherent spontaneous automaticity. It just keeps firing on its own, initiating the normal heartbeat rhythm.
Amazing.
From the SA node, that electrical wave of depolarization spreads outward, first through the right atrium and then efficiently across to the left atrium. As this wave passes, it triggers the contraction of these upper chambers, effectively pushing blood down into the ventricles below.
Okay.
Once the atrial depolarization is complete, the electrical impulse converges on a critical relay station. the atrioventricular junction, or AV junction.
EV junction.
This junction consists of the AV nodal area and the His bundle area. And here's where a critically important physiological delay occurs.
A delay. Why?
It's a momentary pause, typically lasting between, say, 120 to 200 milliseconds. This delay is absolutely essential. It allows the atria to complete their contraction and fully empty their blood into the ventricles before the ventricles themselves begin to contract.
Ah, okay.
Without this precisely timed pause, the heart's pumping action would be far less efficient, potentially leading to blood backing up.
So it's a vital, perfectly timed traffic light, ensuring a smooth flow of blood from the atria to the ventricles.
That's a great way to think of it. Exactly.
Yeah.
After that brief but crucial delay, the impulse rapidly bursts into the HU2 bundle.
Okay.
This bundle then sharply divides into two main high-speed transmission lines, the right bundle branch and the left bundle branch.
Right and left.
These, along with their incredibly intricate network of Purkinje fibers, act like a super-fast electrical grid,
Wow.
rapidly and synchronously transmitting the depolarization wavefronts throughout the entire right and left ventricular myocardium.
Synchronously, that's key.
Absolutely. And for even finer coordination, the main left bundle further fans out into two distinct subdivisions, the left anterior fascicle and the left posterior fascicle. This sophisticated branching ensures the very rapid and highly synchronized activation of the large, powerful left ventricle.
Okay.
Finally, these depolarization wavefronts sweep through the entire ventricular wall, starting from the inner lining, the endocardium, and spreading outward to the epicardium, the outer layer.
Inside out.
Exactly. This endocardium to epicardium spread precisely triggers the coordinated, powerful contraction of the ventricles, ejecting blood into the great arteries and efficiently out to the rest of the body.
Phew. That's quite a trip.
It is. Now, here's a foundational concept for truly understanding the ECG, because these cardiac depolarization or repolarization waves possess both a direction, where they're heading, and a magnitude, how strong they are. They can be precisely represented as vectors.
Vectors. Okay, like in physics.
Exactly like in physics. Understanding these vectors is absolutely crucial for deciphering why the ECG deflections appear exactly as they do. It's fundamental.
Now that we've followed that incredible electrical journey through the heart, how does that translate into those specific waves and segments we actually see etched on the ECG paper?
Yeah.
We've all seen them, the P, QRS, and T waves. What profound insights do they truly tell us? What are we actually looking at?
Those distinct waves are essentially the heart's very own written record of each step in that electrical journey. We label them alphabetically, P, Q, R, S, T, following a convention that's been in place for over a century.
Okay.
The very first wave we typically identify is the P wave. This represents atrial depolarization, the electrical activation that precedes and triggers the contraction of the atria. Its normal appearance offers vital information about the impulse's origin and its smooth spread through those upper chambers.
So P is for the atria.
P is for atria, primarily depolarization. Next, we encounter the powerful and often intricate QRS complex.
The big spiky one.
That's the one. This signifies ventricular depolarization, the rapid electrical activation of the ventricles. Its rapid and complex morphology reflects the highly synchronized and substantial electrical activity occurring across the bulk of the heart muscle, the ventricles, as they prepare for their massive contractile effort to pump blood.
Makes sense. They're bigger muscles.
Exactly. Following the QRS, we observe the ST-TU complex. This comprises the SP segment, the T wave, and sometimes a smaller, more subtle U wave.
Okay.
Together, these components represent ventricular repolarization, the essential electrical recovery or resetting of the ventricles, preparing them for the next beat.
Resetting the ventricles. Got it.
And a crucial anatomical and electrical reference point on the ECG tracing is the J point.
The G point.
Yes, the J point. This is precisely defined as the exact junction where the end of the QRS complex transitions into the beginning of the ST segment. Clinicians pay very close attention to any deviations at this specific point. It's a critical landmark.
Okay.
Now, you might be wondering about atrial repolarization.
I was, actually, if they depolarize.
Right. If the atria depolarize, they must also repolarize. While these repolarization waveforms, sometimes termed STT, do occur, they are generally of too low an amplitude to be clearly detected on a standard surface ECG.
Too small.
Usually. However, they can become unmasked and apparent in specific clinical conditions, such as acute pericarditis or a rare atrial infarction, or certain types of AV heart block where the atrial activity is sort of more electrically prominent relative to the ventricles.
So If I understand correctly, the ECG waveforms are like a direct visual translation of what's happening at the cellular level with those action potentials you mentioned earlier.
Yeah.
The ones that record the electrical events within a single heart cell.
Precisely. There's an incredibly direct and clinically significant correlation between the surface ECG waveforms we see and the intracellular ventricular action potentials, those intricate electrical recordings from individual myocardial fibers. Think of it as peeling back a layer. The rapid upstroke, known as phase 0, of the action potential corresponds precisely to the onset of the QRS complex on the ECG.
Phase 0 to QRS onset.
Right. This upstroke is driven by a rapid influx of sodium ions into the heart cell. Now, if any factors impair this critical sodium influx, for example, critically high potassium levels, hyperkalemia, or certain antiarrhythmic drugs like flecainide, it directly decreases the slope of that phase 0 upstroke. What you then observe on the surface ECG is a distinct increase in QRS duration. The QRS complex visibly widens, indicating a slowdown in the heart's main electrical conduction speed through the ventricles.
So slower sodium means wider QRS. Makes sense.
Exactly. Next, the plateau phase, or phase 2, of the action potential, during which calcium ions are flowing into the cell, corresponds directly to the isoelectric ST segment on the ECG.
The flat part.
That flat line connecting the QRS and the T wave. This represents a period of sustained depolarization.
Okay.
Finally, phase 3, which signifies the active repolarization of the cell as potassium ions flow out, corresponds to the inscription of the T wave.
T wave is repolarization.
Correct. Specifically phase 3. Now, here's where it gets particularly insightful for clinical practice. Conditions that prolong either phase 2 or phase 3 of the action potential, such as specific antiarrhythmic drugs like amiodarone or electrolyte imbalances like low calcium hypocalcemia, will directly and visibly increase the QT interval on the ECG. This means the total time it takes for the ventricles to depolarize and fully repolarize is extended.
Longer QT.
Conversely, factors that shorten ventricular repolarization, such as high calcium, hypercalcemia, or the drug digoxin, will effectively shorten the QT interval.
Shorter QT.
This precise connection is so vital that, for instance, there's a specific genetic condition, hereditary short QT syndrome, which is directly linked to an increased risk of sudden cardiac arrest, underscoring the profound clinical significance of these seemingly subtle measurements.
Wow, that's a deep dive into the cellular mechanics. So it's not just about the shapes of these waves, but also their precise timing and their absolute size.
Absolutely. Timing and size are critical.
How exactly do we measure these on the ECG paper, given that it looks like that standard graph paper grid? This is where the elite professional's precision really comes into play, I imagine.
You're absolutely right. Precision is paramount. The ECG is typically recorded on standardized graph paper, meticulously divided into tiny 1 millimeter grid-like boxes. These grids are essential because they allow for exceptionally precise and reproducible measurement.
Okay, the little boxes.
Exactly. For the horizontal divisions, which measure time, when the recording speed is the standard 25 millimeters per second, each smallest 1 millimeter horizontal division corresponds to exactly 40 milliseconds, or 0.04 seconds.
40 milliseconds per small box.
Correct. You'll notice heavier grid lines on the paper at intervals of 200 milliseconds, or 0.2 seconds. That's 5 small boxes. These make it much easier to quickly count larger time blocks and assess intervals.
Okay.
Vertically, the ECG graph measures the amplitude of a specific wave or deflection, which is essentially its height or depth from the baseline.
Height and depth.
With standard calibration, 1 millivolt MV of electrical potential equals 10 millimeters of deflection on the paper. So 10 small boxes vertically is 1 millivolt.
10 millimeters equals 1 milliV standard.
Standard. And this vertical standardization is particularly important because many voltage criteria used to diagnose conditions like cardiac chamber hypertrophy are explicitly given in millimeters.
Ah, okay. So you measure in millimeters for those criteria.
Often, yes. Now let's break down the major ECG intervals. These are critical for rhythm and conduction analysis and often shown clearly in textbook figures, like a figure 240-2 example.
Right, the key intervals.
First, the RR interval. This is the time measured between the peaks of 2 consecutive R waves, those tall, prominent deflections within the QRS complex.
R wave to R wave.
Exactly. This interval is primarily used to compute the instantaneous heart rate. A quick practical way to estimate heart rate is to divide 300 by the number of large boxes between consecutive R waves.
300 divided by large boxes. Okay.
Or, for more precision, you can divide 1,500 by the total number of small boxes.
1,500 divided by small boxes. Got it.
Second, the PR interval.
Yeah.
This measures the time from the very beginning of atrial depolarization, the start of the P wave, to the very beginning of ventricular depolarization, the start of the QRS complex.
Start of P to start of QRS.
Precisely. This interval normally ranges from 120 to 200 milliseconds. That's 3 to 5 small boxes.
120 to 200 milliseconds.
And this interval is profoundly important because it encapsulates that physiological delay that occurs in the AV junction we talked about.
The traffic light delay.
Exactly. This delay ensures that the atria have sufficient time to fully contract and empty their blood into the ventricles before the ventricular contraction commences.
Crucial timing.
Absolutely. Third, we examine the QRS interval. This reflects the total duration of ventricular depolarization, and it's normally 100 to 110 milliseconds or less.
Under 110 milliseconds, so less than 3 small boxes.
Generally, yes. 2.5 small boxes or less. The QRS interval that is wider than this normal limit can often indicate a significant problem with how the electrical impulse is conducting through the ventricles.
A conduction problem.
Potentially, yes. Finally, and perhaps one of the most clinically critical measurements, is the QT-QTC interval.
QT and QTC.
This interval encompasses both ventricular depolarization and predominantly ventricular repolarization times. It's unique because its duration varies inversely with the heart rate. Meaning as your heart rate speeds up, your QT interval naturally shortens, and conversely, it lengthens when your heart rate slows down.
That dependence on heart rate makes perfect sense physiologically. But it changes with heart rate. How do we get a consistent, reliable measurement for diagnosis? That sounds like a significant challenge for precise clinical assessment. How do professionals handle that?
You've identified a truly critical point in ECG interpretation. It's a major challenge. Because the QT interval is so profoundly rate-dependent, a rate-corrected QT, or QTC, is calculated.
QTC, the C is for corrected.
Exactly. This aims to standardize the measurement, allowing clinicians to compare QT intervals more meaningfully across different heart rates in patients. Many formulas have been proposed for QTC, and there isn't one universally accepted perfect method, actually.
Oh, okay. So there's debate.
There is. The classic square root formula, known as Bizet's formula, QTC equals QT divided by the square root of the RR interval in seconds.
Bizet's. Heard of that.
It's widely known, but it has actually faced considerable criticism for systematic errors, particularly at very low or very high heart rates. This can lead to misinterpretations, either over or underestimating the true corrected interval.
Not ideal.
Not ideal. One widely used alternative that attempts to provide a more consistent correction, especially recommended by some guidelines, is the Framingham formula.
Framingham formula, okay.
Which is QTC QT plus 0.154 times 1000 minus the RR interval in milliseconds. This formula attempts to adjust for rate in a way that minimizes some of the Bizet formula's known biases, particularly at faster rates.
Seems more complex, but maybe more accurate.
Potentially, yes, especially in certain rate ranges. For practical clinical purposes, the proposed upper normal limits for QTC are generally considered to be around 460 milliseconds in women and 450 milliseconds in men, based on the longest measured QT in any lead.
460 for women, 450 for men. Upper limits.
Generally speaking, yes. But it's important for any professional to acknowledge that despite these sophisticated formulas and guidelines, there are inherent limitations in the precise determination of QTC measurements, whether performed visually by a clinician or automatically by electronic ECG machines.
So there's still some wiggle room or uncertainty.
Absolutely. Therefore, clinicians always consider these QTC measurements within the broader clinical context of the patient. You look at their symptoms, their other medical conditions, their medications.
Like a whole picture.
Exactly. This holistic approach is essential for accurate diagnosis and risk assessment, especially regarding the risk of those dangerous arrhythmias like torsades de pointe we mentioned. You can't just rely on the number alone.
If the heart's electrical activity is truly a three-dimensional ballet, how do those flat, two-dimensional squiggly lines on the piece of paper manage to capture all that complexity? It's almost as if you need different cameras strategically positioned around the heart, right? How do these leads actually give us that multi-dimensional view?
That analogy of different cameras perfectly captures the ingenious design and incredible power of the ECG. It's exactly right. The 12 conventional ECG leads are precisely like having 12 distinct video cameras.
12 cameras.
Each strategically placed to look at the same core electrical events, atrial and ventricular depolarization and repolarization, but from unique, distinct spatial orientations.
Different angles.
Different angles. This comprehensive multi-angle view is precisely what transforms the 12-lead ECG into such a profoundly powerful and irreplaceable tool for detailed cardiac assessment.
Okay.
These 12 leads are conventionally divided into two main groups, each providing a different perspective. First, we have the 6 limb or extremity leads.
Limb leads, arms and legs.
Correct. Electrodes are placed on the arms and legs, and they record electrical potentials primarily on what we call the frontal plane of the body. Think of it as a flat plane slicing vertically through the body from head to toe, side to side.
Frontal plane. Got it. Superior, inferior, right, left view.
Exactly, like you see in Figure 243A in many texts. Then we have the 6 chest, or precordial, leads.
Chest leads, V1 to V6.
That's them, V1 through V6. These electrodes are placed directly across the chest wall, and they record potentials transmitted onto the horizontal plane. Think of slicing the body horizontally across the chest.
Horizontal plane. Okay, anterior, posterior, right, left.
Precisely. That setup is often shown in a Figure 243B. The spatial orientation of the frontal plane leads is represented on a hexaxial diagram. You'll see this in Figure 244 typically.
The hexaxial diagram, that circle with all the degrees.
That's the one. It's a truly crucial map for understanding the heart's electrical axis and its projection onto that frontal plane. We'll talk more about axis later. The 6 chest leads, on the other hand, are obtained by placing electrodes in specific, standardized locations across the chest, as detailed often in a Figure 240-5. Precise placement is key here.
Standardized locations, important for consistency.
Absolutely critical for comparing ECGs over time or between patients. Each individual lead, whether a limb lid or a chest lid, has a precise spatial orientation and a defined polarity, a positive and a negative pole.
Polarity. Okay, so an upward or downward squiggle, what we call a deflection, on the ECG trace tells us something about the direction of the electrical wave relative to that camera or lead.
Exactly. This is fundamental to interpreting the ECG. The standard ECG leads are meticulously configured so that if a wave of depolarization, that electrical impulse we've been discussing, spreads towards the positive pole of a specific lead,
Towards the positive pole.
that lead will record a positive or upright deflection, a squiggle going up.
Okay, positive deflection.
Conversely, if the electrical wave spreads towards the negative pole of a lead, you will observe a negative or downward deflection, a squiggle going down.
Towards negative deflection. Makes sense.
And for a truly insightful moment, if the mean orientation of that depolarization vector happens to be at right angles or perfectly perpendicular to a particular lead.
Perpendicular.
Yes, exactly 90 degrees to the lead's axis. You'll observe what's called a biphasic deflection. Part of the wave goes up and part goes down, essentially canceling out as it passes underneath that lead's view.
Biphasic. Okay, up and down.
This core concept of vector direction relative to lead polarity is absolutely fundamental to mastering ECG interpretation. It explains everything we see.
Are there other leads besides the standard 12?
Yes, in very specific clinical circumstances, we have the option to employ supplemental leads. For instance, right precordial leads, typically labeled V3R to V6R.
V3R, V4R, like mirror images on the right side.
Exactly. They're placed on the right side of the chest in positions analogous to V3, V6. These are invaluable when there's a clinical suspicion of acute right ventricular ischemia or infarction. They give a much better view of the right ventricle.
Okay, for the right ventricle specifically.
Similarly, posterior leads, like V7, V8, V9, are sometimes strategically placed on the same horizontal plane as V4, but further back on the patient's left posterior chest.
On the back.
On the back, yes. Their primary utility lies in facilitating the detection of acute posterolateral infarction, a type of heart attack affecting the back wall, which can sometimes be silent or less obvious on the standard anterior chest leads.
So extra views for tricky spots?
Precisely. It's also important to note that while a full 12-lead ECG provides this truly comprehensive multidimensional view, other common monitoring devices like bedside monitors or ambulatory ECGs, think Holter monitors, event recorders, patch electrodes, medical wearables.
Yeah, like fitness trackers sometimes.
Some advanced ones, yes.
Yeah.
These typically employ only 1 or 2 modified leads for continuous monitoring over time.
Just 1 or 2 leads.
Often, yes. While these are excellent for rhythm analysis and detecting transient events like arrhythmias, they don't provide the same intricate spatial information about where exactly things are happening in the heart as a meticulously acquired 12-lead ECG. They serve different purposes.
So what's the detailed blueprint for a truly normal ECG? If we know precisely what typical electrical activity looks like across all those leads, we can then accurately spot the unusual, the subtle deviations. Let's start with the P wave. What does a normal P wave tell an elite professional about the heart's activity? What should we be looking for?
Understanding the nuanced normal is the absolute bedrock upon which all recognition of abnormality is built. It's the essential first step towards mastery. Let's meticulously trace the genesis of each normal waveform, often best exemplified by a perfectly normal ECG, like one you might see in Figure 247 in a textbook.
Okay, the P wave first.
The P wave, as we've discussed, is the electrical signature of atrial depolarization. In a healthy heart, the normal atrial depolarization vector is consistently oriented downward and toward the subject's left.
Down and left, why that direction?
It reflects the natural sequential spread of depolarization, beginning at the SA node high in the right atrium, spreading through the right atrium itself, and then smoothly propagating across to activate the left atrial myocardium.
SA node is high right, so it goes down and left. Okay.
Exactly. Because this normal vector points distinctly toward the positive pole of lead-2, which looks inferiorly and leftward, and simultaneously away from the positive pole of lead-AVR, which looks superiorly and rightward. A sinus-generated P wave will always appear positive upright in lead-2 and negative inverted in lead-AVR.
Always. Up in 2, down in AVR for sinus rhythm.
Correct. This consistent morphology and polarity is defining hallmark of normal sinus rhythm, the heart's natural and healthy electrical pacing originating from the SA node.
What if it looks different?
Good question. Now contrast this with activation originating from an ectopic pacemaker, meaning any pacemaker cells situated somewhere other than the SA node, perhaps in the lower part of either atrium or within the AV junction region.
Coming from somewhere else.
Right. These alternative origins will produce what we call retrograde P waves. They travel upwards through the atria. These will have a distinctly different morphology. They will appear negative, inverted in lead-2, and positive, upright in lead-AVR.
The opposite, down on 2, up in AVR.
Exactly the opposite. This immediate reversal in polarity, compared to the normal P wave, serves as an unmistakable sign to a trained eye that the electrical impulse is not originating from its normal sinus source.
Okay. What about V1?
Good point. Lead V1 sits directly over the right side of the chest, close to the atria. In V1, the normal P wave can often be biphasic.
Biphasic again, up and down.
Yes. It often exhibits both a positive and a negative component. The initial positive component reflects the depolarization of the right atrium, which is closer to V1. This is followed by a small, typically less than 1 millimeter deep and 40 meters wide, negative component that reflects the slightly delayed depolarization of the left atrium, which is further away and more posterior.
So right atrium positives, left atrium negative in V1.
Typically, yes. This biphasic pattern in V1 is a very normal but specific finding for sinus rhythm.
It's truly fascinating how much information is encapsulated within such a small wave. Moving on, what about the powerful QRS complex? How does its normal complex pattern form from those 2 major sequential phases you mentioned earlier? Walk us through that.
The QRS complex is indeed more electrically dynamic and morphologically complex, precisely reflecting the rapid and highly synchronized spread of activation wavefronts throughout the much larger and anatomically intricate ventricular muscle. It's a quick event.
Yeah.
This intricate process of ventricular depolarization can be meticulously broken down into 2 major sequential phases, each characterized by its own distinct mean vector, often illustrated nicely in figures like 246.
Okay, phase 1.
The first phase involves the depolarization of the interventricular septum, the wall that divides the right and left ventricles. This initial activation wave typically proceeds from the left side of the septum towards the right side and also anteriorly. We call this vector 1.
Left to right and forward, septal activation.
Correct. On the surface ECG, this initial septal activation is commonly seen as a small positive deflection, often termed a septal R wave, in a right precordial lead like V1.
Little r in V1.
Simultaneously, in a left precordial lead like V6, which looks for the left side, this same left-to-right septal activation will appear as a small negative deflection, referred to as a septal Q wave.
Little q in V6.
That's right. This initial small Q wave in V6, for example, is entirely normal and just reflects that initial left-to-right septal activation, nothing pathological.
Okay, that's normal. Then phase 2.
The second phase is far more substantial electrically and results from the simultaneous depolarization of the vast majority of both the right and left ventricles.
The main muscle mass.
Exactly. However, because the left ventricle is significantly more massive and electrically dominant, it's the body's main pump. The mean vector for this phase, vector 2, points predominantly leftward and posteriorly. It overwhelms the right ventricular forces.
Left and back, dominant left ventricle.
Precisely. So let's put it together. In a right precordial lead like V1, this overall biphasic ventricular depolarization process results in that small initial positive septal R wave, vector 1, followed by a much larger and deeper negative deflection, known as the S waves, reflecting vector 2 pulling away.
RS pattern in V1.
Typically, yes, a small R, deep S. Conversely, in a left precordial lead like V6, you'll first observe that small initial septal Q wave, vector 1 moving away slightly, followed by a relatively tall and dominant positive deflection, the R wave, vector 2 coming strongly towards it.
QR pattern in V6.
Often a QR, or just a tall R wave in V6.
Yeah.
Again, a clear signature of the substantial leftward electrical forces.
Okay, so V1 and V6 look quite different because of these vectors.
Fundamentally different, yes. And as you meticulously move across the chest with the precordial leads from V1 on the right to V6 on the far left, you observe what's known as normal R-wave progression.
R-wave progression, what's that?
This signifies that the R-wave amplitude generally increases lead by lead, while the S-wave amplitude progressively decreases. The R-wave gets taller, the S-wave gets smaller as you move last.
Okay, taller R, smaller S, going from V1 to V6.
Correct. The specific point where the R and S waves are of approximately equal amplitude is referred to as the transition zone. In a normal ECG, this transition zone usually occurs quite consistently in lead V3 or V4.
Transition zone, V3 or V4, where R equals S.
Exactly. Any significant deviation from this expected R-wave progression, like poor progression, where the R-wave stays small, or reverse progression, can be an important diagnostic clue for various conditions.
And the QRS electrical axis, that's like the heart's main electrical compass direction, telling us the overall electrical orientation in that frontal plane. How do clinicians interpret that, and what do deviations signify for elite professionals? What does it really mean?
That's precisely it. The electrical axis of the QRS is a critical measure that describes the mean orientation of that overall QRS vector, specifically its projection onto the 6 frontal plane leads, visualized on the hexaxial diagram we mentioned, figure 230-4.
Using the limb leads?
Using the limb leads, yes. In a healthy normal heart, the QRS axis typically falls within a broad but defined range, usually considered to be from -30 degrees up to +100 degrees, or sometimes +90 degrees.
-30 to +100 degrees, that's the normal range.
That's a general normal range, allowing for normal anatomical variations in heart position and the subtle nuances of the electrical conduction pathway within healthy individuals.
Okay. What if it's outside that range?
Deviations from this normal range can indeed be significant indicators of underlying cardiac issues. If the QRS axis is more negative than -30 degrees, we call that left axis deviation.
Left axis deviation.
More negative than -30. Right. While it can occasionally be observed as a normal variant in some healthy individuals, it is more commonly and importantly associated with conditions like left ventricular hypertrophy, LVH, where the thickened muscle pulls the axis leftward.
Okay, LVH is a common cause.
It is. LAD is also a hallmark finding in a specific conduction abnormality called a left anterior fascicular block, LAFB, where conduction is delayed in that anterior subdivision of the left bundle.
LAFB, another cause.
Yes. Furthermore, an old, extensive inferior myocardial infarction can sometimes also lead to a left axis deviation because the dead tissue isn't generating signal downwards.
Okay. What about the other direction? Right axis deviation.
Good question. An axis that is more positive than +90 degrees or +100 degrees is termed right axis deviation.
Right axis deviation. More positive than +90 or +100.
Correct. This, too, can sometimes be a normal variant, especially in children and tall, thin young adults whose hearts may hang more vertically.
Normal sometimes.
Yes. It can also be a spurious finding, often due to simple electrode reversal during ECG acquisition, particularly swapping the arm leads. That's why checking technique is vital.
Lid reversal. A trap.
A common one. More clinically significantly, right axis deviation can be a strong indicator of conditions such as right ventricular overload or hypertrophy, whether acute, like a pulmonary embolism, or chronic, like COPD or pulmonary hypertension.
RVH or lung problems.
Often. It can also be a sign of a lateral myocardial infarction, a condition called dextrocardia, where the heart is anatomically positioned on the right side of the chest.
Wow, heart on the right side.
It happens. Also, a left pneumothorax, collapsed lung, which can physically shift the heart, or a left posterior fascicular block, LPFB, that other specific conduction abnormality in the left bundle, though LPFB is much rarer in isolation.
So axis calculation gives a lot of clues.
It really does. Even a simple axis calculation opens up a wide range of diagnostic possibilities that need to be considered in the clinical context.
So, the T wave and U wave effectively wrap up ventricular activity. What do their normal appearances tell us, especially for someone striving for that comprehensive Chapter 240 level understanding?
Right, let's look at repolarization. The T wave is the electrical signature of ventricular repolarization, the crucial electrical recovery phase of the ventricles.
T wave, ventricular recovery.
In a normally functioning heart, the mean T wave vector is oriented roughly concordant with the mean QRS vector.
Concordant, meaning they point in generally the same direction.
Generally the same direction, yes. Usually within about 45 degrees in the frontal plane, sometimes up to 60 degrees of the overall QRS direction. This QRST vector concordance is quite significant and offers a profound insight.
How so?
Since depolarization, QRS, and repolarization, T wave, are inherently opposite electrical processes at the cellular level, this normal concordance on the surface ECG tells us that repolarization in the ventricles normally proceeds in the reverse direction from depolarization.
Reverse direction.
Yes. Depolarization goes endocardium inside to epicardium outside. But repolarization normally goes epicardium back to endocardium. The outer layers recover first. This directionality is what makes the T wave normally upright and leads where the QRS is upright.
Ah, that's why they're usually both upright. Fascinating.
It's key for efficient repolarization and preventing arrhythmias. Now, regarding the U wave, it's typically a small, subtly rounded deflection, usually less than or equal to 1 millimeter in amplitude, that follows the T wave.
Tiny wave after the T.
Usually tiny, yes. In its normal state, it generally possesses the same polarity as the T wave. While its exact physiological origin isn't always fully understood or agreed upon, it's widely believed to represent the late repolarization of the Purkinje fibers, or possibly the mid-myocardial cells, the M cells.
Late repolarization.
However, an abnormal increase in U-wave amplitude is a key clinical sign that an elite professional would immediately note. Prominent U-waves.
Why are they prominent?
It's most commonly associated with the presence of certain drugs, such as dofetilide, amiodarone, sotalol, or quinidine, or, critically, with hypokalemia, dangerously low levels of potassium in the blood.
Low potassium, big U waves.
Very characteristic. Very prominent U waves are an important and often dramatic marker of increased susceptibility to that highly dangerous and potentially fatal ventricular arrhythmia known as torsades de pointe. So seeing prominent U waves is a major warning sign. Understanding the U-wave's context is definitely a hallmark of advanced ECG interpretation.
This is where the ECG truly transforms into a diagnostic powerhouse, moving beyond just normal rhythms to identifying critical health issues. What are some of the most significant abnormalities that an ECG can reveal, and what they tell us about the heart's underlying health? Let's get into the pathology.
This is indeed where the ECG's diagnostic utility truly shines for the elite professional. This is where you apply all that foundational knowledge. Let's delve into some of the major pathological patterns, starting with how the heart's chambers adapt, or fail to adapt, under stress, enlargement, and hypertrophy.
Enlargement and hypertrophy.
Okay. First, we look at the atria. When the right atrium is under acute or chronic pressure or volume overload, it can lead to a noticeable increase in P-wave amplitude, typically measuring 2.5 millimeters or more, particularly in the inferior leads like lead 2. Sometimes you see this in figure 240 to 8 examples.
Tall P waves in lead 2, greater than 2.5 millimeter.
Correct. This pattern was historically, though less precisely, known as P pulmonale, hinting at its association with lung conditions causing right heart pressure.
P pulmonale, right atrial issue.
For the left atrium, chronic overload or even significant conduction delays within the left atrium often produces a biphasic P wave in lead V1 with a distinctly broad and deep negative component.
Biphasic P at TV1 again, but the negative part is big.
Exactly. The terminal negative portion is prominent, often 1 millimeters deep and 40 meters wide. Alternatively, you might see a broad P wave overall, meaning 120 milliseconds or greater duration, often notched in one or more limb leads, especially lead 2. Also shown in figure 240 to 8 sometimes.
Broad notched P waves, like a M.
Sometimes looks like an M, yes. While once termed P mitral because of its association with mitral valve disease, it's more accurately referred to today as left atrial abnormality, as it can signal a structural issue or simply an intra-atrial conduction delay without true chamber enlargement.
Left atrial abnormality. More precise.
More precise. Now, considering the ventricles, right, ventricular hypertrophy, RVH, typically arises from a sustained severe pressure load on the right side of the heart. Think tight pulmonic valve stenosis or significant pulmonary artery hypertension.
High pressure in the lungs or RV outflow.
Exactly. On the ECG, often shown in figure 249 examples, the classic features include a relatively tall R wave in lead V1, where the R wave becomes equal to or greater than the S wave. Normally, the S wave is much bigger in V1.
Paul R in V1, R bigger than S.
Usually accompanied by a right axis deviation, which we discussed. Sometimes a key R pattern may even appear in V1 or V3R, a right-sided lead.
Okay.
A very significant and often ominous finding associated with severe RVH is the presence of a strain pattern.
RV strain, what's that look like?
It manifests as ST depression and T-wave inversion in the right to mid-precordial leads, V1, V3, or V4. This is attributed to altered repolarization in the chronically overloaded and stressed right ventricular muscle itself. It's not ischemia, it's strain.
ST depression, T inversion in V1, V3, V4.
Got it. You might also observe prominent S waves in the left lateral precordial leads, V5, V6, and limb leads, as the electrical forces are shifted rightward.
Okay, what about volume overload, not pressure?
Good distinction. RVH that results from volume overload, such as that caused by an ostium secundum atrial septal defect, a hole between the atria, commonly presents differently. It often shows an incomplete or complete right bundle branch block RBBB pattern, along with a rightward QRS axis. The RBBB pattern is very typical for ASD.
RBBB pattern with ASD. Interesting.
This naturally leads us to cor pulmonale, a condition where the right side of the heart is adversely affected by lung disease.
Cor pulmonale, heart problems from the lungs.
Right. In acute cor pulmonale, often triggered by a large pulmonary thromboembolism, a blood clot in the lungs.
A PE.
Yes, a PE. The ECG can sometimes appear surprisingly normal, or it might just show a sinus tachycardia, which is actually the most common arrhythmia seen.
Just fast heart rate.
Often, yes. But other tachyarrhythmias, like atrial fibrillation or flutter, can also occur. The QRS axis may acutely shift to the right, sometimes presenting with that classic, though not very sensitive or specific, S1Q3T3 pattern.
S1Q3T3. What's that stand for?
A prominent S wave in lead I, a new Q wave in lead 3, and T wave inversion in lead 3. It's just acute right heart strain.
Okay, S and I, Q in 3, T inversion 3.
Correct. Acute right ventricular dilation from the PE can also induce slow R wave progression and STT abnormalities in leads V1 to V4, occasionally mimicking an acute anterior infarction, requiring a very careful differentiation. A right ventricular conduction disturbance, like a new RBBB, might also emerge.
Lots of potential changes with acute PE.
Definitely something to look for. For chronic cor pulmonale, typically associated with long-standing obstructive lung disease like severe emphysema or COPD.
EOPD.
You less commonly observe the classic RVH patterns with tall right precordial R waves. Instead, the ECG often shows slow R wave progression in the right to mid-precordial leads. This might be partly due to the diaphragm pushing the heart downwards and the lung hyperaeration sort of insulating the heart electrically.
Lungs getting in the way.
Kind of. Low-voltage QRS complexes are also quite common across all leads, due to that same electrical buffering effect of the air-filled lungs.
Low voltage and poor R wave progression in COPD.
Common findings, yes. Moving to the left side, left ventricular hypertrophy, LVH, shown in figure 249 examples usually. This is characterized by increased left ventricular muscle mass. It has multiple voltage criteria.
Voltage criteria. Measuring the height.
Measuring the height and depth of QRS waves, yes.
Yeah.
They're based on tall left precordial R waves and deep right precordial S waves. For instance, a very common one is the Sokolow-Lyon criterion. If the depth of the S wave in V1 plus the height of the R wave in V5 or V6 is greater than 35 millimeters.
SV1 plus RV5 then is 35 millimeter.
Okay. LVH can also increase limb lead voltage. For example, the Cornell voltage criteria look at limb leads, like the sum of the R wave in AVL and the S wave in V3 exceeding 20 millimeters in women or 28 millimeters in men, even if precordial voltages aren't dramatically elevated.
Cornell criteria. R in AVL plus S in V3, different thresholds for men and women.
Correct. Critically, just like with RVH, repolarization abnormalities, commonly termed the left ventricular strain pattern, are often present with LVH.
LV strain, similar look.
Similar concept, different location. It typically presents with distinct ST depression and T-wave inversions, but this time in the lateral leads I, AVL, V5, and V6. This strain pattern usually signifies more severe hypertrophy or myocardial stress.
ST depression, T inversion in lateral leads for LV strain?
Typically, yes. That pattern is quite specific for LVH when voltage criteria are also met.
It's interesting that sometimes Even very high voltages can be a normal finding, right? How do clinicians differentiate that? This seems key for mastery.
That's an excellent point for the discerning professional.
Yeah.
It's absolutely true that increased precordial voltages, meeting LVH criteria, can sometimes be a normal variant, particularly in individuals with thin chest walls, such as young athletic individuals.
Athletes and young people.
Yes, this is where patient context is paramount. An isolated voltage finding in a healthy 20-year-old athlete is interpreted very differently than the same finding in a 70-year-old with hypertension.
Context is key.
Always. However, the concurrent presence of left atrial abnormality on the ECG significantly increases the likelihood of underlying LVH, especially in cases with borderline voltage criteria. It adds supporting evidence.
Left atrial abnormality plus voltage equals more likely LVH.
Generally, yes. Furthermore, chronic LVH often progresses over time to incomplete or complete left bundle branch block, LBBB. So seeing LBBB can also be a clue to underlying LVH.
Okay. Are the criteria reliable?
That's a crucial limitation to recognize. The sensitivities of conventional voltage criteria for diagnosing LVH are actually quite low, unfortunately, especially in middle-aged to older adults, obese persons, and smokers. Sensitivity might only be 30–50% in some populations.
So it misses a lot of cases.
It can miss a significant number of cases, and the presence of right bundle branch block can also interfere with the typical LVH voltage criteria.
But it's still important.
Absolutely. Despite these diagnostic sensitivities, ECG evidence of LVH, even if subtle, is a major non-invasive marker of increased risk of cardiovascular morbidity and mortality, including stroke, heart failure, and sudden cardiac death. It tells you the heart has been under strain.
So finding it is clinically very relevant, even if the ECG isn't perfectly sensitive.
Precisely. However, it's vital to stress that due to potential false positive and false negative diagnoses, the ECG has limited utility for definitively diagnosing atrial or ventricular enlargement in isolation. More definitive anatomical and functional information is typically provided by echocardiography, ultrasound of the heart, or other advanced cardiac imaging studies like MRI.
Echo is the gold standard for size and function.
Generally, yes, for structure and function. The ECG tells us about the electrical consequences. Let's transition now to bundle branch blocks and related patterns. These represent distinct interventricular conduction disturbances.
Problems with the wiring, the conduction tissue.
Exactly. The electrical impulse is impaired or blocked within those specialized bundle branches we discussed earlier, leading to a prolongation of the QRS interval because ventricular activation takes longer.
Wider QRS.
Wider QRS. With complete bundle branch blocks, the QRS interval is typically 120 milliseconds or greater, 3 small boxes or more.
Complete block, equal 120 meters.
In contrast with incomplete blocks, the QRS is usually borderline between 110 and 120 milliseconds.
Incomplete, 110, 120 meters.
In these conditions, the QRS vector, particularly the terminal part, is characteristically oriented towards the region of the myocardium where depolarization is delayed. This provides a very specific electrical signature for each type of block.
Okay, let's start with the right side, RBBB.
Right bundle branch block, RBB. You can often see this in figure 24010 examples. Here, the terminal portion of the QRS vector, representing the delayed activation of the right ventricle, is oriented to the right and anteriorly.
Right, and forward delay.
The typical ECG pattern manifests as an RSRA pattern in lead V1.
RSR prime, like rabbit ears.
Exactly, often described as rabbit ears. A small initial R wave, septal, followed by an S wave, LV activation, and then a delayed, taller R prime wave, RV activation. In lead V6, you'll often see a QRS pattern, sometimes with a wide, slurred S wave, reflecting that late rightward force.
RSR in V1, wide S in V6. Got it.
Is RBBB serious?
Interestingly, RBDB is observed more commonly as a normal variant in otherwise healthy individuals than LBB is.
Can be normal.
Can be, especially incomplete RBBB. However, it is also associated with both congenital heart disease, particularly atrial septal defect, like we mentioned with volume overload RVH, and various acquired heart diseases, including valvular, ischemic, or pulmonary conditions affecting the right heart.
Okay, now the left side, LBBB.
Left bundle branch block, LBBB. Also shown in figure 24010 typically, LBBB is generally considered a more clinically significant finding. It profoundly alters both the early and later phases of ventricular depolarization.
More significant, how does it look? The major QRS vector is directed predominantly to the left and posteriorly. What's fundamentally disrupted here is the normal left-to-right septal activation we talked about.
Ah, the septum activates differently.
Completely differently. Instead, septal depolarization proceeds in the opposite direction from right to left.
Yeah.
because the left bundle is blocked.
Right to left septal activation.
As a direct consequence, LBBB typically generates wide, predominantly negative, often QS complexes, in lead V1. There's no initial R wave because the septum isn't activating towards V1 anymore.
Deep QS in V1, no R wave.
Correct. And in lid V6, you see broad, entirely positive, monophasic R complexes, often with a notched or slurred peak. There's usually no septal Q wave either.
Wide notched R in V6, no Q wave.
That's the classic picture. Importantly, waveform patterns that are identical to LBBB, often preceded by a sharp, though sometimes low amplitude, pacing spike, are seen in the vast majority of cases of electronic right ventricular pacing.
Pacemakers look like LBBB.
Pacing from the right ventricle does, yes. Because pacing from the RV apex also results in delayed activation of the left ventricle, mimicking the LBBB pattern electrically. In contrast, biventricular pacing, used in cardiac resynchronization therapy, produces a distinctly different, usually narrower QRS morphology because it activates both ventricles more simultaneously.
So LBBB isn't just a deviation, it's often a significant red flag, signaling underlying issues. You said it was more significant.
Absolutely. While RBBD can be benign, LBBB is frequently a powerful marker of underlying conditions associated with increased cardiovascular risk.
Like what?
This includes prevalent conditions like coronary heart disease, especially when accompanied by impaired left ventricular function, hypertensive heart disease, aortic valve disease. It can even occur after modern interventions like transcatheter aortic valve replacement or TVR and various forms of cardiomyopathy. Finding a new LBBB often warrants further investigation.
So usually means something else is going on.
Often, yes. LBBB can manifest as a chronic, persistent finding, but it can also be intermittent, appearing only occasionally or even rate-related, meaning it only emerges when the heart rate exceeds a certain critical threshold.
Comes and goes.
It can, yes. Rate-dependent LBBB. Now, a very important concept for any professional to master with bundle branch blocks, and indeed with depolarization abnormalities secondary to artificial pacemakers, is the presence of secondary repolarization, STT abnormalities.
Secondary STT changes. What does secondary mean here?
It means the ST and T wave changes are happening because of the abnormal depolarization sequence, not because of a separate primary problem like ischemia.
Ah, it's a consequence of the block itself.
Exactly. With bundle branch blocks, you'll characteristically observe that the T wave is typically opposite in polarity to the last deflection of the QRS. This is elegantly shown in figure 24010.
T wave opposite to the main QRS direction.
Opposite to the terminal part of the QRS, yes. This phenomenon is known as QRST discordance. In LBBB, where V1 is negative, the ST segment is usually elevated and the T wave upright. In V6, where the QRS is positive, the ST is depressed and T wave inverted. The opposite happens in RBB.
Discordance. Okay. Expected with BBB.
It is expected and physiological. It is fundamentally caused by an altered sequence of repolarization that occurs purely as a consequence of the altered, delayed depolarization pathway.
Right. How is that different from primary changes?
This is a crucial distinction to make. It contrasts sharply with primary repolarization abnormalities. Primary changes are independent of QRS changes and are directly related to actual intrinsic alterations in the electrical properties of the myocardial fibers themselves, changes in their resting membrane potential or their action potential duration, like we discussed earlier.
Caused by ischemia, electrolytes, drugs.
Exactly. Those are primary changes. Ischemia, electrolyte imbalances, various drugs like digitalis cause primary STT changes, but the discordance with BBB is secondary.
Can you have both?
Absolutely. Primary and secondary T-wave changes can coexist. That makes interpretation tricky. For example, concordant T-wave changes with the bundle branch block, like T-wave inversion in V1, V3 with LBBB, where you expect upright T-waves, can be an important marker of underlying ischemia or other significant abnormalities that warrant further investigation. It overrides the expected discordance.
Concordant T-waves and BBB equals bad sign, possibly ischemia.
It's a concerning sign, yes. Also, we should mention a distinctive ECG abnormality that simulates RBBB that has specific ST segment elevations in the right chest leads, V1, V3, known as the Brugada pattern. This is a primary electrical disorder, not just a block, and it's a critical marker for increased susceptibility to sudden cardiac death. Needs immediate recognition.
Brugada pattern, RBBB-like with ST elevation in V1, V3. Very important.
Very important genetic channelopathy. We also encounter partial blocks within the left bundle system, often termed fascicular blocks or hemiblocks.
Hemiblocks, blocking just part of the left bundle.
Exactly. Blocking either the anterior or posterior fascicle. Unlike complete bundle branch blocks, these generally do not prolong the QRS duration substantially, maybe just slightly.
QRS not very wide.
Usually not. Instead, their primary manifestation is a characteristic shift in the frontal plane QRS axis.
Axis shifts.
The left anterior fascicular block, LAFB for instance, blocks the anterior fascicle, leaving the posterior fascicle to activate the LV inferior wall first, pulling the initial forces downwards, then the unopposed superior forces dominate. This results in a QRS axis that is more negative than minus 45 degrees.
LAFB axis more negative than negative 45 degrees?
Correct. And LAFB is, in fact, probably the most common cause of marked left axis deviation observed in adults.
Most common cause of LED. Interesting.
In contrast, a left posterior fascicular block, LPFB, blocks the posterior fascicle. This causes initial activation upwards and leftwards, followed by unopposed inferior and rightward forces. This shifts the QRS axis more rightward than plus 120 degrees.
LPFB axis more rightward than plus 110.
Yes. But LPFB is exceedingly rare as an isolated finding. It almost always occurs with RBBB, a bifascicular block. So if you see marked RAD, you need to rule out many other causes like RVH or lateral MI before considering isolated LPFB.
LPFB very rare alone, usually with RBBB.
Correct. Beyond inherent conduction system issues, intraventricular conduction delays, meaning a wide QRS, can also be provoked by factors extrinsic or toxic to the conduction system that significantly slow ventricular conduction velocity.
Like toxins or drugs.
Exactly. This includes conditions like severe hyperkalemia, which we'll discuss more, or the effects of certain medications such as class 1 antiarrhythmic agents like flecainide or propafenone, tricyclic antidepressants, and phenothiazines. They can all widen the QRS.
So wide QRS isn't always a bundle branch block?
Not always. Lastly, it's vital for a comprehensive understanding to note that prolongation of the QRS duration doesn't always mean an underlying conduction delay or toxicity. It can also be due to pre-excitation of the ventricles.
Pre-excitation, what's that?
This is where the electrical impulse bypasses the normal AV nodal delay and travels down an accessory pathway, activating the ventricles early. This is famously seen in Wolff-Parkinson-White (WPW) patterns. The ECG shows a short PR interval and a wide QRS with a slurred onset called a delta wave.
WPW short PR, wide QRS with delta wave. Got it. That's a whole different mechanism.
Completely different mechanism for a wide QRS, yes. Requires specific recognition.
Now let's turn to perhaps one of the most critical and life-saving applications of the ECG, diagnosing myocardial ischemia and infarction, commonly known as heart attacks. This is where the ECG can truly make the difference between life and death, right? This is core Chapter 240 stuff for any professional.
Absolutely. The ECG holds a central and indispensable role in the diagnosis of both acute and chronic ischemic heart disease. This is bread and butter electrocardiography. However, it's profoundly important for any professional striving for mastery to understand its inherent limitations in both sensitivity and specificity.
Limitations, even for heart attacks.
Yes. While a single, seemingly normal ECG certainly does not rule out ongoing ischemia or even an acute infarction, especially if symptoms are ongoing.
Okay, a normal ECG doesn't mean no heart attack.
Correct. But a truly normal ECG tracing throughout the entire clinical course of an acute myocardial infarct is distinctly uncommon. Conversely, prolonged chest pain without any diagnostic ECG changes should always prompt a very careful and thorough search for other non-coronary causes of the symptoms. Don't anchor just on the ECG.
Got it. Clinical picture matters.
Always. Acute ischemia exerts complex and time-dependent effects on myocardial cells. In severe acute ischemia, the resting membrane potential of the heart cells lowers, and critically, their action potential duration shortens.
Cells change electrically when starved of oxygen.
They do. This critical cellular change creates a voltage gradient, or electrical difference, between the normally perfused and the acutely ischemic zones of the heart muscle. This gradient drives what we call currents of injury. Think of it like electricity flowing between the damaged and normal areas, often shown well in Figure 24011 diagrams.
Currents of injury, okay.
These currents, in turn, are precisely represented on the surface, ECG, by characteristic deviation of the ST segment from the baseline, specifically at the J point.
ST segment deviation, that's the key sign.
It's a key early sign of acute injury, yes. When the acute ischemia is transmural, meaning it involves the full thickness of the heart wall,
Full thickness injury.
the net ST vector typically shifts profoundly toward the outer epicardial layers, pointing toward the injured area. This produces distinct ST elevations and sometimes, in the very earliest moments of an infarct, incredibly tall, peaked, positive, hyperacute T waves directly over the ischemic zone.
ST elevation and hyperacute T waves. transmural injury.
This pattern signifies a medical emergency, an acute vessel occlusion, requiring immediate action like reperfusion therapy.
Okay. What if it's not full thickness?
Conversely, if the ischemia or injury is confined primarily to the subendocardium, the inner layer of the heart wall,
Subendocardial injury, inner layer only.
the ST vector typically shifts towards the subendocardium and the ventricular cavity, pointing away from the overlying leads. This results in characteristic ST segment depression in those overlying leads, such as the anterior precordial leads. Often, you'll see reciprocal ST elevation in lead AVR, which looks electrically from inside the cavity.
ST depression, often with ST elevation in AVR,
That's right.
subendocardial injury.
Correct. The absolute amplitude of these ST deviations, whether elevation or depression, can be an indicator of severity. Profound ST elevation or depression in multiple contiguous leads usually indicates very severe and widespread ischemia or injury.
Bigger changes mean bigger problem.
Generally, yes.
So this is the fundamental distinction that leads to the clinical terms STEMI and NSTEMI, right? Based on ST elevation or not.
Precisely. From a critical clinical perspective, the division of acute myocardial infarction into ST segment elevation myocardial infarction, STEMI, and non-ST elevation myocardial infarction and STEMI types is exceptionally useful. It drives immediate management decisions.
Why is that distinction so important?
Because the efficacy of emergency reperfusion therapy procedures aimed at rapidly restoring blood flow to the blocked coronary artery, like thrombolytics or primary angioplasty, is primarily and profoundly established for STEMI, where you assume a total vessel occlusion. In STEMI management is usually initially different, often involving medications first.
STEMI, emergency reperfusion, and STEMI, often meds first. Big difference.
Huge difference in initial strategy. While less common, it's worth noting that Takotsubo syndrome, often referred to as stress cardiomyopathy, can closely simulate the ECG patterns of acute STEMI or NSTEMI, highlighting the need for careful clinical correlation and sometimes further testing like coronary angiography to differentiate.
Takotsubo can mimic MI. Good point.
The ECG leads are typically more helpful in precisely localizing the regions of ST elevation than they are for non-ST elevation ischemia, which can be more diffuse.
So STEMI location is easier to pinpoint.
Generally, yes. For example, acute transmural ischemia affecting the anterior wall of the heart, supplied often by the LAD artery, including apical and lateral areas, is reflected by ST elevations or increased T-wave positivity in one or more of the precordial leads, V1, V6, and often leads 1 in AVL.
Anterior STEMI, V1, V6, I, AVL.
Inferior wall ischemia, often RCA or circumflex artery, characteristically produces changes in leads 2, 3, and AVF. Those look at the bottom of the heart.
Inferior STEMI, 2, 3, AVF.
Posterior wall ischemia, which almost invariably occurs with concomitant lateral or inferior involvement, often circumflex, may be indirectly recognized by reciprocal ST depressions in leads V1 to V3, the mirror image changes.
Posterior STEMI. Look for ST depression in V1, V3, reciprocal changes.
Exactly. These reciprocal changes are, in effect, an ST elevation equivalent indicating posterior injury. Using those posterior leads, V7, V9, can show direct ST elevation.
Right, and the right ventricle.
And critically, acute right ventricular ischemia, usually with an inferior MI from RCA occlusion, typically produces distinct ST elevations in the right-sided chest leads, V3R or V6R, as in figure 240-5. Acquiring these supplemental leads is crucial when inferior STEMI is present.
RVMI. Need right-sided leads like V4R.
Essential for identifying RV involvement, which impacts management. The ECG evolution of an infarction, especially a STEMI, often follows a classic and predictable sequence over time. You might see this in figure 240-13 examples.
How does it change over time?
When ischemic ST elevations appear as the earliest sign of acute infarction, they are typically followed within hours to days by the dynamic evolution of T-wave inversions, and often by the development of pathological Q waves in the very same lid distribution where the ST elevation was.
So ST elevation, LHT inversion, however, the typical evolution.
That's the classic evolution of a Q wave MI, yes. It's a progressive, time-dependent process reflecting tissue injury and necrosis.
What about temporary ischemia, like angina?
Good point. Reversible transmural ischemia, for instance, that caused by coronary vasospasm, as seen in Prinzmetal's angina, can induce transient ST segment elevations that look just like a STEMI, but then they resolve completely within minutes when the spasm releases, without subsequent Q wave development.
Transient ST elevation resolves quickly, spasm.
Right. These ST elevations may resolve completely, or they might be followed by T wave inversions that can persist for hours or even days after the ischemic episode.
Okay. What about specific T-wave patterns?
Patients experiencing ischemic chest pain who present with deep, symmetric T-wave inversions in multiple precordial leads, such as V1, V4, and sometimes I and AVL, often with minimal or no cardiac enzyme elevation initially, may have severe critical obstruction in the left anterior descending LAD coronary artery. This pattern is sometimes referred to as Wellens T-waves, figure 240 of 12.
Wellens T-waves. Deep symmetric T inversions in V1, V4. High-risk LAD lesion.
Exactly. It's a very high-risk finding indicating impending large anterior MI. Needs urgent attention. With infarction, specific depolarization, QRS, changes often accompany or follow the repolarization, SCT abnormalities.
QRS changes too.
Yes. The necrosis, death of a significant amount of myocardial tissue, can lead to a decreased R-wave amplitude, or the development of abnormal Q waves in the leads overlying the infarct zone, as in figure 240-13. The dead tissue doesn't generate electrical potential, creating an electrical hole.
Q waves mean dead tissue, basically.
That's the classic teaching. Historically, abnormal Q waves were dogmatically believed to exclusively mark transmural myocardial infarction, while subendocardial infarcts were thought not to produce Q waves.
Q wave equals transmural. Non-Q wave equals subendocardial. Old idea.
That was the old, somewhat simplistic idea. However, advanced correlative studies using imaging like MRI have definitively shown that transmural infarcts can occur without Q waves. Conversely, subendocardial infarcts can sometimes be associated with Q waves. Not a perfect correlation.
So it's more complex.
It is. Therefore, evolving or chronic infarcts are now more accurately classified simply as Q wave or non-Q wave infarcts, based purely on the presence or absence of a pathological Q wave on the ECG, rather than assuming the transmurality based on the Q wave alone.
Just Q wave versus non-Q wave MI. Got it.
Furthermore, the loss of depolarization forces due to a posterior or lateral infarction may paradoxically cause reciprocal increases in R-wave amplitude in leads V1 and V2. The loss of opposing forces makes the anterior forces look bigger.
Tall R waves in V1, V2 can mean posterior MI.
Can be an important clue, yes, especially if accompanied by ST depression there. It's the electrical equivalent of Q waves posteriorly. Again, those additional posterior leads, V70, V9, can be acutely helpful in demonstrating direct Q waves or ST changes in that situation.
Okay. Do these changes last forever?
Over weeks and months following an infarction, these characteristic ECG changes may persist, or they may gradually begin to resolve, especially the STT changes. Q waves are more likely to persist long-term if the infarct was large. Complete normalization of the ECG after a Q wave infarction is uncommon, but certainly possible, particularly with smaller infarcts or if reperfusion was very successful.
Okay. What if the ST elevation doesn't go away?
Good question. ST segment elevations that persist for several weeks or more after a Q wave infarct usually correlate with a severe underlying wall motion disorder, akinesis or dyskinesis, in that segment, meaning the muscle isn't contracting properly. It doesn't necessarily mean a frank ventricular aneurysm, though, which is a more specific anatomical finding.
Persistent ST elevation equal bad wall motion.
Usually, yes. Needs further investigation, often with echo. Now, it's absolutely vital to reiterate the ECG's crucial limitations in mimickers. These are often referred to as pseudo-infarct patterns, and you might see lists in tables like Table 240.1. This is where errors can happen if you're not careful.
Mimickers, things that look like MI but aren't.
Exactly. The ECG, while powerful, has inherent limitations in both sensitivity and specificity for ischemic heart disease. A major challenge is that diagnostic changes of acute or evolving ischemia are often masked or significantly obscured by the presence of LVBB, electronic ventricular pacemaker patterns, and WPW pre-excitation.
LVBB, pacers, WPW, height ischemia.
They can make it very difficult, sometimes impossible, to diagnose acute MI based on the ECG alone. There are specific criteria, like Scarbosa criteria for LDBB, to try and detect MI in these settings, but they're not perfect. Interpretation becomes exceptionally challenging and requires advanced expertise.
Okay, that's masking. What about false alarms? Overdiagnosis.
Conversely, clinicians must be wary of overdiagnosing ischemia or infarction based on ECG patterns. This can occur when ST segment elevations or depressions, T wave inversions, tall positive T waves, or Q waves are interpreted as ischemic but are not actually related to ischemic heart disease at all.
Seeing ST elevation that isn't an MI.
Precisely. For example, ST segment elevations that can closely simulate acute ischemia infarction can occur with acute pericarditis or myocarditis, including from infections like COVID-19. These often have more diffuse ST elevation, PR depression, and a different shape.
Pericarditis. Diffuse ST elevation.
Also, a common and benign normal variant called early repolarization can cause ST elevation, especially in young athletic individuals, often in V2, V5.
Early repolarization. Benign ST elevation.
Other causes listed in Table 240.2.1 include the Brugada pattern we mentioned, effects of Class 1C antiarrhythmic drugs, sometimes transiently after DC cardioversion, and hypercalcemia, severe hyperkalemia, or profound hypothermia, where you see those distinctive J waves or Osborne waves at the J point.
Lots of non-MI causes of ST elevation.
A lot. Similarly, tall T waves don't always signify hyperacute ischemia. They can be normal variants, classic for hyperkalemia, or related to acute cerebrovascular injury like a stroke.
Tall T waves. Hyperkalemia, stroke, normal.
Furthermore, Q waves, which we classically associate with infarction, can also be present in numerous non-infarction contexts.
Q waves aren't always old MI.
Not always. They can be physiologic positional variants, e.g. a Q in lead-3 can be normal. They can occur with ventricular hypertrophy, especially septal Qs and LVH, acute or chronic non-coronary myocardial injury, like myocarditis or cardiac contusion, hypertrophic cardiomyopathy, often deep, narrow Qs, and various ventricular conduction disorders.
Hypertrophic cardiomyopathy has Q waves.
Often prominent septal Q waves, yes. ST segment depression that mimics subendocardial ischemia can be caused by ventricular hypertrophy, the strain pattern, hypokalemia, drugs like digoxin, digitalis effect, and many other factors.
ST depression mimickers too. Strain, low K, digoxin.
Finally, prominent T-wave inversion, while concerning for ischemia, can occur with ventricular hypertrophy, strain, various cardiomyopathies, myocarditis, stress cardiomyopathies like Takotsubo often has deep TWI later, and specific types of cerebrovascular injury, particularly intracranial bleeds, causing those dramatic, wide, deep CVA T-wave patterns.
CVA T waves, deep inversions from brain bleed.
Yes. Diagnostic confusion can also arise from non-ischemic T-wave inversions known as the cardiac memory effect.
Cardiac memory, what's that?
This occurs in normally conducted beats in patients who intermittently have wide QRS complexes, most commonly due to intermittent ventricular pacing or intermittent LBBB. When normal conduction resumes, the T waves can be inverted in leads where they were upright during the wide QRS, remembering the abnormal repolarization. It can mimic ischemia, but isn't.
Wow. So T waves remember the BBB or pacing. Tricky.
Very tricky. This is precisely why clinical context, a systematic approach, and a deep understanding of mimickers are absolutely paramount for mastery. You can't interpret in a vacuum.
It's clear that it's not just structural heart issues or blockages that leave their distinct mark on the ECG. Our body's intricate chemistry and even common medications can drastically alter the electrical picture, right? This seems like another crucial area for the elite professional to master, as these changes can provide vital immediate clues, maybe even before lab results are back.
You've hit on a profoundly important aspect of ECG interpretation.
Absolutely.
This is where the ECG provides vital, immediate diagnostic clues about systemic conditions. A wide variety of metabolic abnormalities and pharmacologic agents can significantly alter the ECG, particularly affecting the critical repolarization phase manifesting in the STTU complex and sometimes even causing QRS prolongation. Certain life-threatening electrolyte disturbances, for example, can often be initially diagnosed and then subsequently monitored primarily through their characteristic ECG changes.
Like potassium.
Potassium is the classic example. Take hyperkalemia, or dangerously high potassium levels. You might see this in figure 240.14. It produces a remarkably characteristic and sequential set of ECG changes as the level rises.
What's the sequence?
It usually begins with a narrowing and a peaking or tenting of the T waves. They become very tall and pointed, often with a narrow base.
Peaked T waves. First sign of high K?
Usually the earliest reliable sign. As potassium levels continue to rise, you'll observe progressive AV conduction disturbances, like a prolonged PR interval or even heart block, a significant diminution or even complete disappearance of the P wave amplitude.
P waves flatten and disappear.
Yes. And a widening of the QRS interval, reflecting that slowed ventricular conduction we discussed.
Wide QRS.
Okay. In severe hyperkalemia, the ECG can rapidly evolve into a slow, broad sinusoidal or sine wave pattern where the QRS merges with the T wave. This is a pre-arrest rhythm. If not urgently treated, it will tragically lead to ventricular fibrillation or a systole and cardiac arrest.
Sine wave pattern. Very bad. Needs immediate treatment.
Immediate. Conversely, hypokalemia, or critically low potassium levels, often shown in figure 240.15, typically prolongs ventricular repolarization.
Low K, what does that do?
It often leads to ST depression, T-wave flattening, and importantly, the appearance of very prominent U waves. The QT interval may also be prolonged, although the QU interval, including the U wave, is often markedly prolonged.
Low KST depression, flat T, prominent U waves, long QU.
That's the classic picture. Then there are numerous QT prolonging drugs. This is a huge area.
Drugs that make the QT interval longer.
Yes, medications that fundamentally increase the duration of the ventricular action potential, delaying repolarization. This broad category includes Class 1A antiarrhythmic agents and related drugs like quinidine, disopyramide, procainamide, as well as tricyclic antidepressants and many antipsychotics like phenothiazines.
Okay, Class 1A, TCAs, antipsychotics.
It also includes Class 3 antiarrhythmic agents such as amiodarone, as shown sometimes in Figure 24015, dofetilide, sotalol, and ibutylide. Many non-cardiac drugs too, like certain antibiotics, macrolides, fluoroquinolones, and antifungals.
Class 3 antiarrhythmics, and others. Why is a long QT bad?
The clinical significance of this drug-induced QT prolongation is profound. A markedly prolonged QT interval, especially when caused by these factors, indicates a significantly increased susceptibility to that dangerous polymorphic ventricular tachycardia called torsades de pointe.
Torsades de pointes, triggered by long QT, potentially fatal.
Exactly. Recognizing QT prolongation and its cause is critical for preventing torsades. Other critical metabolic and drug effects include those from systemic hypothermia, low body temperature, often shown in Figure 24015. This also prolongs repolarization, long QT, but it's often distinguished by a very distinctive convex elevation right at the J point.
The Osborn wave.
Exactly, the Osborn wave or J wave. It's a characteristic little hump right after the QRS. Pretty specific for hypothermia, although it can be seen in other conditions too.
Osborn wave equals hypothermia, usually.
Usually. Marked QT prolongation, sometimes accompanied by very deep, wide T-wave inversions, can occur with certain intracranial bleeds, particularly subarachnoid hemorrhage. This is often referred to as the striking CVA T-wave pattern, also might be in Figure 24015. The mechanism isn't fully clear, possibly autonomic storm.
CVA T waves again. Long QT and deep inversions with brain bleed.
Yes, can be very dramatic. Calcium levels also have a direct and observable impact on the ECG, primarily affecting the ST segment duration, and thus the QT interval, Figure 24016 usually shows this.
Calcium, how does that affect it?
Hypocalcemia, or low calcium levels, typically prolongs the QT interval, specifically by lengthening the ST portion of the interval. The T wave itself might be normal.
Low calcium, long ST segment, long QT.
Correct. In stark contrast, hypercalcemia or high calcium levels causes a characteristic shortening of the QT interval, again primarily by shortening or even obliterating the ST segment. The T wave seems to start right after the QRS.
High calcium short ST segment is short QT.
That's the typical finding. Lastly, digitalis glycosides like digoxin, a class of heart medications used for conditions like heart failure and atrial fibrillation, are well known to shorten the QT interval, mainly ST segment, and produce distinctive non-ischemic ST wave complex changes, often referred to as the digitalis effect. This includes ST depression that looks scooped or sagging and flattened or inverted T waves. It doesn't necessarily mean toxicity, just drug effect.
Digitalis effect. Short QT scooped ST depression. Doesn't mean toxic levels necessarily.
Correct. Specific patterns suggest toxicity, but the basic effect is common at therapeutic levels. These specific electrolyte and drug patterns are often immediately recognizable to an experienced eye, providing instant diagnostic clues. Beyond these distinct specific abnormalities, we frequently encounter what are termed nonspecific STT changes and low QRS voltage.
Non-specific changes, the frustrating ones.
It can be frustrating because they don't point to one thing. Nonspecific STT changes, which encompass subtle findings like T-wave flattening, minimal T-wave inversions at less than 1 millimeter, or slight ST segment depression are, by definition, not specific to any single condition.
So what can cause them?
Oh, an incredibly vast array of clinical scenarios. Various electrolyte and acid-based disturbances, widespread infectious or inflammatory processes, even common viral infections, central nervous system disorders like anxiety or stroke, endocrine abnormalities, e.g. thyroid dysfunction, the effects of countless different drugs, mild ischemia, hypoxia, virtually any type of cardiopulmonary abnormality, and even simple physiologic changes related to posture, hyperventilation, or after large meals.
Basically anything.
Pretty much anything that affects the heart or body systemically can cause subtle STT changes. Because they are so nonspecific, while they might prompt further investigation depending on the context, They rarely pinpoint a diagnosis on their own.
Okay, what about low voltage?
Low QRS voltage is another intriguing finding that warrants attention. It's arbitrarily defined as peak-to-trough QRS amplitudes of 5 millimeters or less in all 6 limb leads and/or 10 millimeters or less in all 6 chest leads.
Small QRS complexes everywhere, 5 millimeters in limb, 10 millimeters in chest.
Correct. While less dramatic than some other changes, multiple factors can be responsible, some quite serious. It suggests something is dampening the electrical signal reaching the surface.
What kind of things dampen the signal?
Among the most critical causes are large pericardial effusions, fluid around the heart, shown maybe in figure 240-17, or large pleural effusions, fluid around the lungs. The fluid effectively acts as an electrical buffer and diffuses the signal.
Fluid, pericardial or pleural effusion.
Other serious causes include chronic obstructive pulmonary disease, COPD, due to the hyperinflated lungs, infiltrative cardiomyopathies like amyloidosis, where abnormal proteins infiltrate and disrupt the heart muscle, often causing low voltage despite thick walls.
Amyloidosis, low voltage plus thick heart, classic mismatch.
A classic finding, yes. And severe anasarca, or generalized edema throughout the body, which also significantly diffuses the electrical signal. Obesity can also cause relative low voltage.
COPD, amyloid, severe edema, obesity, all can cause low voltage.
They are key considerations when low voltage is present.
This last category sounds quite dramatic when the ECG literally starts alternating its beat-to-beat appearance. What profound implications does that signify for an elite professional?
Indeed, that's what we refer to as electrical alternance syndromes. Electrical alternance is fundamentally defined as a beat-to-beat alternation in one or more components of the ECG signal. The amplitude, morphology, or axis changes every other beat.
Alternating beat to beat.
Yes, it's a fascinating and often critical type of nonlinear cardiovascular response to various hemodynamic and electrophysiologic perturbations within the heart. When you observe total electrical alternance, meaning that the P waves, the QRS complexes, and the T waves all show a distinct beat-to-beat alternation.
Everything alternates. P, Q, R, S, T.
Yes, the entire complex changes amplitude or shape every other beat, as clearly seen in figure 240-17 examples, especially when accompanied by sinus tachycardia. This is a relatively specific and highly concerning sign of a significant pericardial effusion, almost invariably accompanied by cardiac tamponade.
Total alternans plus tachycardia equals tamponade.
Highly suggestive, yes. Cardiac tamponade is that life-threatening condition where fluid accumulation around the heart severely restricts its ability to fill and pump blood effectively. While total electrical alternance has high specificity, meaning if you see it, it's very likely tamponade, its sensitivity is limited, meaning not all tamponade cases will display this specific finding. You can have tamponade without alternance.
High specificity, low sensitivity.
Got it. In contrast, pure repolarization alternance, where only the STT segment or the U wave alternates on a beat-to-beat basis, while the QRS stays the same.
Just STT or U wave alternates?
Yes, sometimes called two-wave alternance. This is a different phenomenon with its own critical implications. This is generally considered a dire sign of electrical instability within the heart muscle itself. It reflects beat-to-beat variations in action, potential duration, across the myocardium.
Electrical instability.
Yes. And it may precede serious and life-threatening ventricular tachyarrhythmias, like ventricular fibrillation. It signals that the heart is on the very verge of a dangerous, chaotic rhythm disturbance. It's a marker of high arrhythmic risk.
So repolarization alternans is a major warning sign for arrhythmias.
A very significant marker, yes. Recognizing these different types of alternans and their distinct implications is definitely a hallmark of truly advanced ECG interpretation.
What an incredible journey we've taken today, unraveling the complex narrative of the ECG. From the tiny electrical impulses to the complex pattern signaling disease, it's abundantly clear that the ECG is so much more than just a few squiggly lines. You, our listener, now understand its alphabet, its grammar, and even some of its poetic nuances, hopefully heading towards that Chapter 240 mastery. So with all these intricate patterns and possibilities, how do those elite professionals actually approach reading an ECG? Is it purely intuitive pattern recognition, or is there a systematic, meticulous method they follow every single time?
It is absolutely a systematic approach, combined, of course, with a great deal of acquired experience and meticulous clinical correlation. You need both. Accurate analysis of ECGs demands not just knowledge, but profound thoroughness and meticulous care. You can't rush it.
Thoroughness and care.
One of the most common pitfalls, leading to critical mistakes in ECG interpretation, even by experienced professionals, is often an error of omission, simply missing a subtle but vital piece of information. because a systematic approach wasn't rigorously followed. They jumped to a conclusion too quickly.
Errors of omission. Missing things.
Exactly. Crucially, you must always integrate the patient's age, gender, and their overall clinical status into the interpretation.
Mm.
An ECG finding that might be a completely normal variant for a young, well-conditioned athlete could be a highly abnormal and concerning signal in an elderly patient with known heart disease presenting with chest pain.
Context, context, context.
It's paramount. It transforms raw data into meaningful clinical insight. To truly avoid those errors of omission and ensure comprehensive analysis, a systematic, rigorous approach is essential. Think of it as a detailed checklist, a mental diagnostic compass that every expert methodically goes through with every single ECG they read.
A checklist approach. Okay, what's on the list?
Well, you need to cover everything methodically. It involves about 14 key points.
14 points. Okay, let's hear them.
First, assess the standardization, calibration, and technical features. Is it calibrated correctly? 10 millimeter. Is the speed right? 25 millimeters. Are the leads placed correctly? Any obvious artifacts? Get the basics right first.
1, technical quality check.
Second, determine the fundamental rhythm. Is it sinus? Is it atrial fibrillation? Is there heart block? What's the underlying rhythm?
Rhythm.
Third, accurately calculate the heart rate, average and instantaneous if needed.
3, heart rate.
Fourth, precisely measure the PR interval and critically assess AV conduction. Is it constant? Is it prolonged? Are there drop beats?
4, PR interval AV conduction.
Fifth, measure the QRS interval for its duration and overall configuration or morphology. Is it narrow or wide? Is there a bundle branch block pattern?
5, QRS interval morphology.
Sixth, meticulously assess the QT and QTC intervals, noting any prolongation or shortening, keeping rate correction in mind.
6, QT-QTC intervals, crucial for arrhythmia risk.
Absolutely. Seventh, determine the mean QRS electrical axis in the frontal plane. Normal, left, right, or indeterminate.
7, QRS axis.
Eighth, thoroughly examine the P waves. Are they present? Are they related to the QRS? What's their morphology? Any signs of atrial abnormality?
P waves, atrial activity.
Ninth, critically evaluate the QRS voltages. Are they normal, high, suggesting hypertrophy, or low?
9, QRS voltages.
Hypertrophy or low voltage causes.
10th, carefully check for precordial R-wave progression across V1 to V6. Is it normal? Is the transition zone appropriate?
10, R-wave progression transition zone.
11th, diligently look for any abnormal Q waves or significant loss of R-wave amplitude that might suggest prior infarction. Are they wide enough, deep enough, in the right leads?
11, abnormal Q waves are wave loss. Infarction signs.
12th, scrutinize the ST segments in every lead. Any elevations, depressions, or other deviations from the baseline compared to the TP segment, localized or diffuse.
12, ST segments, ischemia, injury, strain, pericarditis.
13th, analyze the T waves. What's their shape, amplitude, and polarity? Are they concordant or discordant with the QRS? Any primary abnormalities?
13, T waves, repolarization details. And finally, 14th, examine the U waves. Are they visible? Are they prominent? What's their polarity?
14, U waves, electrolytes, drugs, arrhythmia risk.
Going through these 14 points systematically every single time ensures you don't miss anything important.
That's comprehensive. Seems like the only way to achieve mastery.
It is. Furthermore, the value of comparison cannot be overstated. Comparing a current ECG with any previous ECGs from the same patient is truly invaluable.
Comparing to old ECGs, why is that so important?
It helps detect subtle, evolving changes that might indicate an acute or worsening condition, like evolving ischemia. It's also crucial for differentiating new findings from old, established patterns that may be chronic and stable, like an old Q wave or chronic LBBB. It tells you what's new versus what's baseline for that patient.
Distinguishing acute from chronic. Critical.
This longitudinal perspective is a hallmark of sophisticated interpretation. Finally, we must acknowledge the widespread integration of computerized electrocardiography. Computerized systems are now ubiquitous.
The machine reads it first.
Often, yes. They enable immediate retrieval of thousands of ECG records and provide an initial automated analysis and interpretation, calculating intervals, axis, and offering diagnostic statements.
Sounds helpful. Does it replace the expert?
And this is an absolutely critical point for anyone striving for true mastery in this field. These fully automated computerized ECG analyses still have major limitations. They are algorithms based on pattern recognition, and they can be fooled by artifacts, subtle variations in morphology, complex arrhythmias, or clinical context that the algorithm doesn't know.
So the computer can be wrong.
Absolutely. Misinterpretations by automated systems are common, sometimes dangerously so. Therefore, these automated analyses should never be accepted without careful, independent clinician review of both the waveforms and the intervals. The human expert must always overread the computer interpretation.
Always need the expert eye to confirm we're correct.
Always. They are a helpful first pass, a tool to assist, perhaps flag potential issues, but they do not replace expert human oversight and interpretation, especially when integrated with the clinical picture. True mastery lies in understanding both the tool and its significant limitations.
What an incredible journey we've taken today, diving deep into the heart's electrical language. From the tiniest cellular impulses to the complex patterns signaling disease, it's profoundly clear that the ECG is so much more than just a few squiggly lines.
Mhm.
It's a dynamic, intricate story unfolding in milliseconds and millimeters.
Indeed. What's truly fascinating here is how this small, non-invasive, and readily available test offers such an extraordinarily rich tapestry of information. It's quite amazing, really.
Yeah.
It empowers clinicians to connect subtle electrical clues to the bigger picture of a patient's health, often enabling immediate life-saving interventions. It powerfully underscores how critical thinking combined with a foundational knowledge from sources like Chapter 240 and that systematic, meticulous approach we discussed
Right.
transforms raw electrical data into profoundly valuable, actionable insights.
And for you, our curious listener, the next time you see an ECG, you'll know you're looking at a symphony, a complex story told in precise electrical signals. You now have, hopefully, a master key to unlock some of its most profound secrets.
And that understanding, that ability to truly decipher these fundamental signals, asking the right questions, knowing the patterns and the pitfalls, that's the very hallmark of mastery, allowing you to appreciate the hidden language of the human body.
If the heart's intricate electrical activity can tell us such a comprehensive and critical story, what other seemingly simple signals in our daily lives, maybe even outside of medicine, might hold similarly complex and critical information, just waiting for us to learn their language and decipher their true meaning? Something to think about.